Hello, and welcome to the Health Boardroom. I'm Ron. Today's episode is very timely. We are diving deep into the new national level guidance on responsible AI use in healthcare. Artificial intelligence is transforming healthcare at pace. From diagnostics to workflow automation, ambient voice technologies, predictive models, decision support. But with the promise comes real world risks, bias, safety, governance gaps, regulatory uncertainty. In this boardroom conversation, we'll unpack the latest guidance, what's expected of organizations, what governance structures need to be in place, how healthcare and life science leaders should rise to the challenge, and definitely how you personally, as a leader, can turn this into strategic advantage. So let's get started. First, let's set the context. Why now? Why is responsible AI use in healthcare a board level and executive level issue? The pace of AI deployment in healthcare is accelerating. For example, the American Heart Association, aka AHA, recently issued a science advisory emphasizing that although hundreds of AI tools have been cleared by the US, only a fraction of those tools have been robustly evaluated for clinical impact, fairness, or bias. In the UK, the governance ecosystem for AI in healthcare continues to evolve, with major regulatory bodies flagging fragmentation, the need for coordination, and reliance on soft law guidance rather than hard statutes. At the same time, healthcare organizations are under pressure: cost constraints, workforce shortages, quality and safety demands. AI presents a dual opportunity and risk. A board or executive who treats AI as just a tech product checked risks overlooking governance, ethics, regulatory data, and safety issues. We now have fresh guidance at national or near national levels recommending formal governance committees for AI in healthcare, involving clinical operations, IT, compliance, data privacy, etc. Which means this is no longer just to do later, but must do now. So the imperative is clear. The risks include safety incidents, bias, or inequitable outcomes, regulatory breach, reputational harm, and opportunity includes improved efficiency, better outcomes, differentiations, and future readiness. Now, let's understand what the new guidance actually says. For many organizations, the big shift is from ad hoc AI tool adoption to governed lifecycle management of AI. So let's unpack each. The first one is governance and policies structures. According to the guidance published by the Joint Commission in collaboration with Coalition for Health AI in September 2025, organizations should establish formal AI governance structures to oversee the responsible use of AI tools. These governance teams should include representatives from clinical, operational, IT compliance, safety, stakeholder groups, both patients or providers, right? Not just the tech or IT team. Policies should align internal standards and external regulatory or ethical frameworks and can be regularly reviewed. This means your board or executive must ask: do we have an AI governance committee? Who sits on it? How often does it meet? And what is its charter? The second one is risk, bias, and validation across the life cycle. The AHA advisory outlines a risk based evaluation and monitoring framework for AI tools deployed in cardiovascular and stroke care specifically, but the principles apply broadly. It emphasizes that only 61% of the hospitals validated predictive AI tools on local data, and fewer than half tested for bias. The Joint Commission guidance emphasizes ongoing monitoring, post development, local validation, bias assessment, and vendor disclosures. As a leader, you must ensure that AI tools are not just plugged in, but validated in your context, monitored for drift, bias, and safety issues. Third point is that I wanted to discuss is transparency, consent, and patient agency. Guidance stresses that patients should be informed when AI tools directly impact their care. And organizations should ensure transparency about how data is used, what the AI tool does, and what decisions it supports. Even where tools are not subject to full regulatory oversight, the ethical imperative remains: data protection, access controls, encryption. So, as the board, think, how are we disclosing to patients and staff about the AI use? What governance ensures this? One of the major issues in AI in healthcare is bias across patient populations. The AHA advisory emphasizes use of representative data sets, validation across populations, and assessment of bias or risk. The broader international guideline sets out principles like fairness, explainability, traceability, robustness, and usability. For executive teams, equity is not a nice to have, but a strategic requirement. So, if you deploy AI that works for one population but fails for another, you create quality, safety, and reputational risk. Talking about monitoring, lifecycle management, and tool retirement, the AHA guidance states that monitoring of AI tools cannot end after deployment. Performance may drift as clinical practice changes or patient populations differ. The UK's National Health Service (NHS) guidance on ambient scribing products similarly requires a monitoring framework, hazard logs, safety case, and ongoing audits. NHS England board questions: do we have a defined life cycle for each AI tool we use? Who governs retirement or retraining? The UK ambient scribing guidance emphasizes completion of data protection impact assessments, integration with EPR, which is electronic patient record for them, and EHR for us, cybersecurity controls, and compliance with medical device regulations wherever applicable. The Joint Commission guidance similarly emphasizes encryption, access controls, vendor contractual safeguards, even where HIPAA may not apply. So, from an executive vantage, make sure IT and compliance are at the table, and that procurement of AI tools is aligned with existing regulatory or information governance frameworks. So, if we are to sum this up, I will say governance, risk and bias, transparency or consent, equity, monitoring and life cycle, data protection or integration. These are the pillars of the new guidance. If your organization addresses these proactively, you will be ahead. If you wait, you risk being behind. Now, let us turn from what the guidance says to what you must do as a board or executive team. Because guidance without implementation is just aspiration. So, first of all, board oversight and governance, I'll say, make AI governance a formal agenda item. The board should understand AI use cases in your organization, the risk profiles, the oversight of mechanisms. Consider establishing or empowering an AI governance committee that reports to the board and includes stakeholders, clinical operations, IT informatics, data privacy, compliance, legal, quality, safety, patient representatives, and define clear charters like selection criteria for these AI tools, vendor assessments, validation requirements, monitoring of deployed tools, metrics, incident escalation. Second, what you can do is like strategic alignment. For an example, align AI use cases to your organization's strategic goals. What those goals can be, like improved outcomes, efficiency, patient experience, and equity. Avoid pilot for the sake of pilot. The AHA advisory emphasizes strategic alignment as one of its four guiding principles. And you can develop a roadmap for AI adoption. Prioritize which areas are highest impact and feasible within your governance or risk appetite. Third, I believe a vendor or third party AI products must be treated like medical devices or clinical tools. You need to validate on your local data, assess bias, ensure transparency of vendors' algorithms or training data if possible. The Joint Commission guidance makes vendor disclosures a key expectation. Establish tool validation and monitoring protocols. Example, pre deployment local validation, post deployment performance dashboards, drift detection, incident reporting. Ensure contractual protections, vendor liability, audit rights, data sharing rights, updates or trainings or maintenance results, reporting result reporting obligations. Then AI tools rarely deliver value in isolation, right? We all know that. They must integrate into clinical workflows, EHRs, existing IT systems, staff training, or change management. The UK Ambient Scribe Guidance highlights workflow and integration as critical. So, I'd recommend engaging clinicians early. Ensure they understand the AI tool, its purpose, its limitations, how outputs will be used. Train staff on what to watch for. Monitor the human machine interaction. For instance, over reliance on AI outputs without review can create risk. The guidance says users must review outputs before taking further actions. Then document policies for usage. Like, when is the AI approved for direct patient care versus decision support versus administrative use? What governance applies at each level? Set expectations and metrics around fairness and bias. The new guidance emphasizes bias testing, representative datasets, equity of outcomes. Ensure data governance structures like data access controls, de identification wherever appropriate, encryption, regular audits. Even when HIPAA does not apply, data protection must be robust. Prioritize inclusive designs. When deploying AI, ensure underserved populations aren't excluded or disadvantaged. Monitoring and auditing and continuous improvement is also recommended. So develop data dashboards to monitor key performance metrics of deployed AI, accuracy, safety events, bias indicators, drift, user adoption, outcomes. Establish triggers or thresholds for retraining or retirement of tools. The AHA advisory emphasizes that performance drift must be identified and addressed. AHA audit incidents and near misses involving AI tools. Feed them into your quality or safety committee. Integrate AI oversight and into existing risk frames. Those can be potential things that you can do as a board member. Leadership must set the tone. AI is not just IT, but strategic, clinical, organizational. Boards must ask questions. allocate resources, and hold teams accountable. Create a culture of safe innovation. Encourage pilots, but with governance. Encourage experimentation, but with clear risk or benefit, data, and transparency. Train clinicians and staff in AI literacy, what it can do, what its limitations are, how to interpret AI outputs, and how to escalate any concerns. Communicate to the staff and patients about how AI is being used. Transparency builds trust. The guidance emphasizes informing patients when AI supports their care. Engage patients or public wherever appropriate. Their perspectives can help identify unintended consequences or fairness issues. And be prepared for regulatory or ethical audiences, accreditation bodies, regulators, privacy data, protection authorities may increasingly ask for AI risk governance documentation. Right? Let's get pragmatic. What can you do right away? What what are the quick wins? And what's your checklist for the next 90 days? First of all, believe board briefing, right? Ensure your board has an agenda item which says AI governance in healthcare in the next board meeting. Provide an executive summary of the new guidance, your current AI tool inventory, and the governance gaps. Second, you can do is catalog all AI or ML tools currently in use or under procurement in your organization. For each tool, clinical impact category, high, medium, low, patient facing versus admin, vendor life cycle status, right? These three can be the categories that you can start with. Define charter, membership, clinical, IT, compliance, data, or safety, whatever is there, and meeting frequency as well. Third, I believe vendor and tool validation audit is a must. So for each tool in inventory, check, has local validation been done? Has bias been assessed? Are monitoring metrics in place? Are there contractual obligations for vendor about updates or performance? Then draft or review policies covering AI tool selections. Make SOPs, right? Deployment monitoring, retirement, vendor management, transparency or disclosure to the patients, include all these. And then monitor the dashboard designs. Decide on key performance indicators for these AI tools. Yes, like, accuracy, bias matrix, drift detection, adoption rates, incident reports. Assign responsibility. Begin education campaign. That's what you can also do. Like what AI tools are in use, how they should be used, what are their limitations, and when to escalate concerns. I've been repeating this again and again because team training is necessary. Draft communication that explains to the patients, you know, how AI tools are being used in their care, ensuring transparency and consent where required. Review data sources, patient populations, tool performance across diverse groups, like identify any unknown or suspected bias, and set plans for corrections. I believe integration and data protection check are also necessary at this point of time. Like for each AI tool, check whether integration with the EHR or IT systems is safe, whether DPIA has been completed or not, encryption or access controls are adequate or not. For each tool, define a life cycle. Who will review the tool annually? And in cases if it is more frequently it is needed, who will do that? Right? What triggers will indicate a retraining or retirement of that tool? And I believe, after having these things in place, reporting to the board is necessary. Right? So at the next board meeting, present status, inventory, governance, committee established, major gaps identified, roadmap, resources required. So, before we wrap up, a quick look at some common pitfalls and how you can avoid them. Pitfall number one that I'll share with you is treating AI as just another IT project. So, if you delegate AI entirely to IT without clinical and governance involvement, you miss clinical risk, safety, bias, and strategic alignment. And how you can avoid it? Engage clinical leadership, operational leadership, data privacy compliance teams from the very start. Talking about pitfall number two, over trusting vendor slides without local validation. Most of us does do this. Guidance shows many hospitals skipped local validation or vendor assessment or bias assessment. How you can avoid it? Build requirement that vendor must provide performance data. You must test locally and monitor continually. Pitfall number three, neglecting data governance, integration, and workflow. Tools might be certified but fail when deployed because data pipelines, integration, user workflow are weak. The UK Ambient Scribe guidance emphasizes integration. How you can avoid it? Include IT, informatics, and clinical workflow experts in planning and deployment, forgetting equity and bias. If you deploy AI that works only for a subset of patients or a specific population, you create a risk of inequitable care. How to avoid it? Test for representative data, bias matrix, and monitor outcomes across different patient groups. Pitfall number five, failing to monitor post deployment. AI models drift, populations change, practice evolves. The AHA advisory emphasizes monitoring cannot stop at deployment. So, simple. How to avoid it? Set monitoring thresholds. Define when to train or retire. Integrate into quality or safety frameworks. Pitfall number six, lack of transparency with patient and staff. If stakeholders don't understand AI use, trust will be low and uptake will suffer. So communicate clearly, train your staff, and involve patients wherever appropriate. With this, thank you for joining me on this episode of the Health Boardroom. If you found this conversation insightful, share it with a colleague or healthcare leader exploring how AI is reshaping cost, care, and strategy. And do not forget to subscribe because next time we may bring a guest with us, someone who's on the front lines of building a smarter, more human centered healthcare system and making their own contribution towards a better future of care. Until then, stay thoughtful, stay curious, and keep reimagining what healthcare can be. I'm Ron, and this is the Health Boardroom.